Okay, unfortunately, once you start sharing, you can't see yourself. So if somebody can, maybe you confirm, can you see the slides?
Yes, doctor. Ocular trauma.
Excellent. All right. So today I want us to talk about ocular trauma, and the idea would be just to cover basic principles. In previous years, we actually used to do this in 2 sessions, but we've compressed it now. So what we'll do is cover the theoretical part, but because you'll have tutorials, the examination of the eye has been deliberately trimmed down from this lecture so that we can talk about it practically in a tutorial session. So my aim this morning will be to just broadly describe the terminology we use for describing injuries of the eye and how we classify them, because you're going to hear some repeated terminologies that I'll use throughout the lecture. Then I'd like us to understand the epidemiology of eye injuries locally being in Kenya, but I'll also show you 1 or 2 slides on data from the US. Then I'll probably dwell a little more on history taking for eye injuries, because I think this is probably the most important part of this lecture. The rest of the things about what type of injury this is, you can get from textbooks and pictures, but we'll also cover them in tutorials where we have lots of photographs. Then I'll briefly go over the principles of examination, how we examine the eye. Then the details will be covered during those tutorials. Then we'll go over principles of managing. Principles are just things that apply regardless of what kind of injury it is, or whether it's how to examine or how to manage. Talk a bit about prevention and rehabilitation after eye injuries. So some of the main injuries we'll look at in your tutorials, because these are the common ones we see, will include, lead injuries, hemorrhages, fractures, complications of blunt trauma, and I'll show you something about this later. Then how to manage intraocular foreign bodies and chemical injuries. These are broadly the most common things we see. So instead of going through each of them in detail, we'll cover broad principles. Then during tutorials, you will see many different types of injuries in the wards and clinics. So internationally, there is a terminology system that everybody has agreed on. And broadly, we divide an eye injury into 2, an open globe injury or closed globe injury. By an open globe injury, we mean the injury has gone through the full thickness of the eye wall. So whether the eye wall is the cornea or the sclera, if you remember your anatomy well, if there's been a breach through the cornea, all the way, full thickness of the cornea or the sclera, that qualifies as an open globe injury. In a closed globe injury, the eye wall does not have a full thickness wound. Now that may mean that it has a lamella wound, or the entry, meaning the entry did not go through and through, so it's part of the wall of the cornea or part of the wall of the sclera, or it may simply be a blunt injury. The eye wall appears intact, but we have injury inside the eye. Then the open ones are characterized as lacerations or ruptures. A rupture is caused by a blunt object. So if a child is hit by a stone and there's a rupture of the eye wall, full thickness, that's a rupture. But when it's a sharp object, a pencil, a knife, a stick, then that is called a laceration. So you'll often hear people, interchangeably using some of these words and saying laceration, perforation. Essentially what we mean, the strict word is laceration. It means it's gone through, caused by a sharp object. That object could be an intraocular foreign body. Sometimes you have, pieces of shrapnel when there's an explosion, pieces of metal when people are working with grinders in the Gichuhi industry or they're welding. And then we like to distinguish a penetration from a perforation. A penetration means there's only an entrance, and a perforation means we have an entrance and an exit. So if something has gone right through the cornea, for example, we may call that a perforation because it is a laceration, because it's gone through, it's an open globe injury caused by a sharp object that has cut through. it has both an entry to the cornea and an exit of the cornea into the anterior chamber. Some wounds will just, for example, if a piece of metal, high speed, goes through the sclera and gets stuck inside the lens or in the vitreous somewhere, then it did not exit. So that becomes a penetrating injury. I don't think at your level you should be too concerned about these terminologies, but I think if you just know up to the level of a laceration and a rupture, and for a closed globe injury, you just want to be sure that it's a closed globe injury, that will be good enough for your level. These are mostly used in trauma audits and registries. So what's the epidemiology of eye injuries? Usually epidemiology talks about who is affected, where are they affected, and when. So generally we'll tend to talk about who is at risk of injury. When we say when, we probably will talk about when do injuries tend to occur most. And if I don't mention that, please remind me. Then we'll talk about, what did I say? Where do injuries tend to occur? So just to begin with, very broadly to cover the story of this epidemiology, you need to be aware we have very poor data worldwide. And that was some of the ideas that drove the development of that Birmingham criteria I showed you, because people wanted to create registries so that we have data on injuries. And one of the biggest problems that has led to this lack of data is the way we define blindness internationally. Blindness is defined using the vision of both eyes. So we say vision is less than 3/60 in the better eye, which means the worse eye is worse than that. So if you're defining something using both eyes, that creates a problem, because somehow most injuries tend to be unilateral, which means one eye can get injured and it has no perception of light, which is totally blind. But because the other eye is still 6/6, for example, that patient is not classified as blind, which seems unfair if you think so. So some of the earliest data or latest data you'll find from the WHO still talks about data that was produced in 1998 when I was finishing my MMed. So that's old data. So don't even look at this. So we've done various studies, and I'll present just a few of the studies we've done with our registrars for their master's projects. So this was one registrar called Muridhi, who's now an ophthalmologist somewhere in Meru. And he had his study looking at ocular trauma of admitted children in KNH in 2008. And you can see here that we mostly had, for every column of age, you can see there are more males affected than females, and the male to female ratio was 2:1. So when we're talking about who is affected, even among the children, you can see the boys that were twice as likely to get injured with an injury severe enough to be admitted in KNH, more than the girls. Also in terms of age, I think you can begin to see that, especially if you look at the taller bars, the ones for the males, there seems to be two peaks of incidence, and these are mainly that's the top one there, and that you can see is just about it's at age 4, and then we have another one here at age 7. And one may want to ask, is there an explanation? This was a cross-sectional study, so we couldn't find an explanation that could generate a hypothesis. And some of the hypotheses may be that now these are the children who are starting to attend, who are starting to play a lot more independently. And then at this age, they're starting to go to primary school and interacting with their friends and playing a lot. But those are hypotheses. We have not done any studies to verify that that's the cause. So in that same study, the peak age of it was 4 years. You could see it was higher than the rest. And then using that terminology, I told you 70% of the injuries were open globe injuries. And open globe injuries are more severe generally than closed globe. Some of the data we also looked at is how long do they take between the day they were injured and going to the first health facility. And you can see it was 1 day. So usually when there was a severe injury, they quickly got to a first health facility. and then they start being referred from there to the, today it would be from the sub-county to a county hospital, then they end up being referred to a level 5 hospital. So in our case, the average time it took between injury and admission to KNH was 3 days, which is quite long. The median hospitalization was 7 days. And also knowing the socioeconomic status of a lot of our people, even at that time, about a quarter of the hospital bills had to be waived because the patients couldn't pay. And so epidemiology tells us a lot of information. So we are beginning to see a story now that people who are affected travel long distances, they very quickly get to a fast facility, but it looks like a lot of the early facilities are not able to handle these injuries. And so they end up being referred up. And by the time they get to a referral facility like KNH, it's 3 days. And that's an average, which means there are some who took longer and some shorter. When you have to waive a quarter of your bills, it tells you the socioeconomic status of the people you're dealing with. What were the causes of injury? That's the table on the right. Sorry, the types of injury. And you can see that the most common injury was a corneal perforation. Almost 2/3 of the patients had corneal perforation. Iris prolapse was the next most common one. The iris prolapses through the wound. And I'll also tell you that most of these patients with corneal perforations also had iris prolapse, because when the cornea is torn or is perforated, the iris pops out as the aqueous gushes out. You can see the next most likely cause, about 1/3 of the patients had cataracts, and the rest of the injuries, as you see there. Retinal detachments, which few and rare. What caused the injury? The most common object in children this age, you can imagine, was a stick, followed by stones, and then knives and wires and nails and pens and glass. And some of these are rare things like whips and fists and tire bursts. So the thing I want you to notice is, this is generally what you'll find kids doing. And, be careful when you see kids, throwing stones at things or throwing stones at each other, not aware where the stone will land on the other end, throwing stones over a wall where they can't see where the other side is. So just notice that most of this happens because kids are playing unsupervised. And that's the common thing in a lot of our communities. The kids are always playing away from the parents or from an adult. Then we also had somebody else do a study. This was another registrar called Funjika. She was from Zambia. Now she's an ophthalmologist there. And from her work, she was looking at, so Murithi looked at children, and now we did this study looking at adults who had been admitted in KNH during the period of 2005 to 2009. And again, notice male to female ratio. This is even higher now. It's 7:1. I guess one would say the adult women are less likely to engage in high risk activity than younger girls. But the pattern still continues. Injuries are more common in men than women. The peak age for this period, median, was 29 years. These are young, economically productive people. And while I said that the injuries that when children occurred at play, most injuries in adults occur during work. And again, also notice that by the time we're admitting you, usually you have open globe injuries, 91%. 79% of patients presented to a health facility within 72 hours of injury. In this case, for the adults, 60% came directly to KNH. You remember the children mostly went somewhere else and then they were referred. These ones came directly to KNH, and 40% were referrals from outside. One may wonder why, but because you can imagine most of these injuries are occurring at work. These injuries that occur when kids are playing somewhere outside by themselves will probably not be discovered until later when the parents come back home. For the adults, if this is happening at work, and especially in a formal workplace setting, then there's more likely to be attention to prevent medical legal things of sending into hospital directly. What were the types of injuries? Again, if you notice, this pattern only presented differently on the right-hand side, the most common injury, again, you can see was a corneal perforation, almost the same proportion as the children we saw earlier. And scleral lacerations were the other common injuries. The others were less frequent. I will share these notes so you can have a look at that. So just notice, what are the top line themes? Corneal perforations, scleral perforations, very common injuries. Most injuries are open globe, you can see that. In this case of adults, what were the causes of injury? The most common object was metal. And this was mostly, grinders, welding, pieces of metal that people are offloading from lorries, and then one piece of, especially iron bars, the ones used for construction. You're offloading them and accidentally you're pushed, they usually hold 2 or 3 people. So one person is at the lorry offloading it and pushing it backwards, and it pokes somebody's eye behind them. Glass was also very common. Again, in factories, this is fairly frequent. Sticks and twigs and stones were less frequent. But again, you see here something you probably don't see as much in children, the road traffic accidents and fists. Then we had explosions and chemical burns. So somebody else, Dr. Momanyi now, who is also working in the western part of the country, his MEd project looked at the pattern of ocular injuries in Eldoret at Moi Teaching and Referral Hospital. We had done the others in KNH. This particular study now looked at both inpatients and outpatients. And I want you to notice the pattern still continues. Males are more often affected than females. The median age was 24 years. These are young, economically productive people. So you can imagine losing your eyeball or losing your vision, in the prime of your life. 70% of the injuries were open globe. Sticks were the most common agent, and stones. You might ask why. So in Eldoret, MTRH gets a lot of referrals of people coming in from the surrounding farming areas. So while in Nairobi, most of the injuries were occurring at a workplace that was either a factory or, a Juakali business premises, in this case, the workplace is a farm. So most injuries would involve sticks and stones. A tractor is harrowing a farm and a stone is thrown, somebody's following and it hits his eye. So again, notice 3 days from injury to admission. So people in rural places will probably go to a first facility and end up being referred on, and it takes 3 days to get to hospital. So some of this data is useful because then you begin to understand the patient you're seeing and by the time they're coming to your hospital. So if you're working in a lower level facility, then it is important that you try and manage appropriately what needs to be done, and if there's any referral to be done, to emphasize that it is done quickly. So the table on the right shows what were the common injuries, types of injuries. Now, because here we had outpatients, the most common one was actually corneal foreign body. Notice on the top row, there were no inpatients admitted with it because corneal foreign bodies are not as serious, and usually it's a piece of stick or stone or metal or something on the cornea. We remove it in the clinic, put the patient on antibiotics, patch the eye, and discharge them. But notice all the patients with corneal foreign bodies were actually outpatients. Also, just look on the top row that out of 524 patients, 121 were inpatients. The majority, 403, were actually outpatients. So most eye injuries do not require admission. They are not as serious if they are appropriately managed. But if you don't deal with a corneal foreign body well, you can end up having keratitis, perforation, even endophthalmitis. And now we come to the next most common injury, was a corneal laceration or perforation. And again, I want you to see that about 2/3 of them were inpatients, but we still had a third that were treated as outpatients. So if an entry wound didn't go through, some of them you can actually put antibiotics and patch them, or use bandage contact lenses and send them home. Then I think we had data, yes, on the setting of the injury and the age. The age we talked about earlier in the earlier slide. But the peak age for the men was 24. Notice for the peak age for the girls is earlier, 0 to 10. So the females are mostly going to be injured when they were children. Then you can see the green columns go reducing with time. The men, we have this peak in children, and then we have this peak in adults. So I should also have mentioned that in Momanye's study, this one, we looked at everybody, adults and children. So what was the setting of the injury? Most injuries occurred at home, and home doesn't mean sitting in the house. These are farming communities, people are working outside. The most common, second frequent site of injury is actually the assault from injuries. And because it was a mixture of adults and kids, then you could say home may have had a higher preponderance because of the children, and industries or workplace may appear less. Farming may appear less, but if you combine these two, because these are workplaces, farming and industry, then you can see this would end up being about just more than 25%. So it would be the next most common setting of injury here. Because you have noticed that most of the injuries tend to be anterior segment injuries involving the cornea, we were also interested in finding out, so what happens to posterior segment injuries that go further to the back of the eye? So this study was done by a registrar at that time, Dr. Grace Nguyo, who's now an ophthalmologist also in Meru. And her study looked at the pattern of posterior segment injuries after ocular trauma at the vitreoretinal unit in Kikuyu Eye Unit, just up the road near Alliance High School. And we collected the same style of data in all the studies. And here you can see again, males were more frequently affected than females, almost 3 to 1. The mean age is 27.8 years, so young adults in their productive age. Now, interestingly here is for posterior segment injuries, road traffic accident was the most common cause, which you haven't seen with the previous slides. Again, majority were now here, majority were closed globe injuries. So 75% were closed globe injuries. So you remember in my first slide, I was telling you most open globe injuries are very severe. Closed globe injuries may not be so severe, but I also want you to notice that majority of those closed globe injuries will be associated with posterior segment injuries, which we can see on the column and the illustration on the right. Also, about half the people concurrently had anterior segment injuries. And the vision is very poor by the time they are coming to the hospital. 84% were blind, meaning that eye had vision of less than 3/60. And so what were the types of posterior segment injuries? The illustration on the right shows you that about half had retinal detachments, 49%, and also 47% had vitreous hemorrhage. Most of these people had concurrent red detachments and hemorrhage, because if you've had an injury in the eye, you tend to get bleeding from the ciliary body. Somebody needs to mute, please. Somebody is very busy typing. Please mute yourself. So this is data from Kenya. And now just a look at what's the picture like internationally. This was a paper that was published looking at the US database. They have had a database for a long time, looking at hospitalizations for eye trauma. And you can see the primary and secondary here means was the eye injury the primary reason the person has been admitted. So you can see that the incidence for primary admissions is low because is lower than secondary, because secondary represents people who have had an eye injury plus another injury that has resulted in hospitalization. And you can imagine road traffic accidents and things like that would be associated, and trauma, assault would be associated with injuries, fractures, injuries in the chest, head injuries. So those would be the primary reasons for admission, and the eye is a secondary reason. The frequency of diagnosis for those hospitalized patients. Now, in this case, their injuries were mostly orbital floor fractures in the primary group. And you can imagine in road traffic accidents and falls from heights, people, they get orbital fractures. They don't have Gichuhi industry like we do, so our pattern of injuries will be very different. Lacerations of the lid are important, and perforation, penetrating wounds of the orbit. So looking at people with eye trauma again, what's the age distribution? Distribution by age, you can see that majority of people are adults, and the next highest column, that's 36% there, almost 37. Then the next highest column, notice, is elderly people. Old people are at very high risk of injuries from falls and other things. And especially in these Western societies, people live by themselves. Most older people are, unlike here, would not be living with their children or grandchildren. But we are also changing very quickly, I must say. And then the next was children. Males, again, more often than females. Look at race, again, because of the racial constitution, it's hard to conclude anything. Most people are white, so most of them will get the injuries. Then by the income quartiles, something interesting you see here, which we see here as well, the highest proportion is actually in the lowest quartile of income. Poorer people are more prone to injuries than wealthier people. The wealthier kids have toys. Wealthier people work in safe job environments, in offices and industries where they have protection. Less endowed people will probably end up doing more high-risk occupations. So epidemiology tells you a lot of interesting information. Good. So now let's go to the initial patient assessment. And by way of introduction, I need to emphasize here that injuries affect people, not just eyes. When somebody has had an injury, don't just say it's an eye injury. They've been through trauma. They've been through a terrifying experience. Somebody has been assaulted. Somebody has been involved in a fight. One kid has injured another. So there tend to be a lot of anxiety about visual loss. You never really appreciate the value of what you have until when you don't have it. So some people may think the eye is a small organ in the body, but until you lose one, then you get very anxious about losing your vision. So you'll be dealing with somebody who is very anxious. If it's a child, the parents are very anxious. Even if it's an adult, whoever has brought them because they care and they have a lot of anxiety. So it's a fairly tense environment. Patients with eye injuries usually have pain. They're very frightened. So you need to have a very gentle and reassuring approach when you're dealing with them. When they panic, don't panic with them. You need to manage anxiety in both the patient and whoever is accompanying them. And you really need to be calm. It's good to be very sympathetic and reassuring, but yet you must remain authoritative. You're the doctor. Once the environment is settled, then, inquire gently about what happened and when it happened. Please notice the questions I'm asking. What happened and when? The first question is not who, because people come and say, I was assaulted. Oh, who injured you? That's not the important thing. Right now, the patient in front of you, what we need to know is what happened and when. If you suspect an accidental injury, basically a deliberate injury, handle this particularly delicately. If there was domestic violence, work-related injury, or violence by somebody who they may know, then you need to be very careful because there's very likely a medical legal component to it. So focus on the patient and the injury, not on who caused the injury. When people tell you I was injured in a bar, don't get diverted into where were you drinking? That's not the issue. Obtain information without assigning blame. Don't start blaming who took long to refer, who treated you inappropriately. Whoever did this must have done a very bad thing. Don't make those kind of comments. You want to be reassuring without being unrealistic also. So it's an interesting, delicate balancing act here. And that's why some of these things are best learned by actually clerking patients and seeing them. And you learn to communicate with people. So, you can say something like the injury is very severe, but we will do everything we can. So that's both reassuring, but also not offering hope that you can't guarantee. Don't say this injury is very severe, but we'll make sure you leave here seeing. If you're not sure of the prognosis, don't say such things. Just say, we don't know yet, or, we've done a test, let's see how we get on. And please blame nothing but the injury. Don't start blaming who has been involved in the care before, because you were not there. So on to history now. It's best to just let the patient talk. Just listen to them. Don't interrupt, listen. You want to pick up details as they're talking, things like, where was this injury? Where was the location where the injury occurred? You want to find out things like, were you using safety equipment? Do you use safety glasses? If it was a car accident, were they wearing seatbelts? You're just listening. And if they don't say any of these things, then you'll come now and start filling in the details. So, you were in a vehicle, are you wearing a belt? If it's, a vehicle that has an airbag, did the airbag deploy? Because some of the injuries may be caused by airbags. And, even little babies get killed by airbags. So if you have small toddlers, by the way, don't put them on the front seat. Put them on the back seat. Put them in a child seat in the back seat. I've seen people putting those baby seats on front seats. And please belt in every young child. I've had friends who lost their children because kids were not wearing belts, head-on collision, child is thrown out through the windscreen, and then you go and run over them. A detailed description of the mechanism of injury is really important. And by mechanism of injury here, we mean you want to remember that table at the beginning. You want to classify, was this a laceration? Is it an erosion? Is it an open injury or closed? Because the mechanism can tell me. If somebody says I was hit by a stone, then I'm thinking we may be dealing here with either perforation, or maybe it was a ruptured globe. If somebody splashed a chemical, I'm not so worried about that having penetrated, like a penetrating injury, but then chemical injuries have their own unique thing, and I want to know, is that an acid or an alkali? Burns, thermal especially, radiation, what were the circumstances? Were you hammering? Were you chiseling? Because that gives me the impression that this is going to be a high-speed injury. If somebody was grinding, hammering, or chiseling something, a piece of metal can dislodge at very high speed, and that can go quite far into the eye. If it's a gunshot, of course, then there's shrapnel and things that can go very far into the eyeball. Lathe machines, grinders, and drills also, you're thinking corneal foreign body, maybe it just got stuck on the cornea, or it may have gone right through. Welders are very prone to UV injuries because of that bright light. And I think you walked in Gichuhi places and seen how people like doing this work without even wearing goggles. In fact, they think it's a very macho thing to do it without goggles. Those who wear goggles are made fun of. If somebody says I fell from a height, then you're thinking there could be orbital injuries. Also, the nature of foreign body is very important. You want to hear what caused this injury. So was it a stick? Was it a piece of metal? High-speed piece of metal usually tends to be a very high temperature when it's going into the eye. So it's probably sterile, but it also means it may go in very far. A piece of stick or stone is not good because those may carry a lot of organisms from the soil. And you remember some of those bugs that are found in soil, fungal material from vegetative matter. So you need to know what caused the injury. It's important to know the exact time of the injury. Always note down when. And I should also mention that when you're taking history, please write down everything. When did the injury occur? You remember we've said by the time you're in KNH, if you're working in KNH, you're seeing them 3 days later. So you need to know when did the injury occur so that I look at the wound and say, does this look like a wound that's consistent with the time period I'm being told about? Or is this somebody who got injured a week ago, but they're saying they were injured yesterday because they got some brilliant idea that they might be able to get money out of this? So you're a bit like a detective. You need to know the place of injury. That's important, because if it's a workplace, then usually there tends to be a workman's compensation involved. What first aid was given? That's also very important to record. Where was it given? How? Who gave it? Then you want to have an idea of the previous ocular history. Have you had surgery before? Have you had an injury before? People who have had an injury in one eye are very prone to getting another injury in the same eye. Because if, for example, you lose vision in that eye, then you lose your binocular visual field, you lose your stereopsis, so you can't judge depth and distance. So you're more likely to get injured again. Have you had vision problems before? Did you used to wear specs? Have you had a squint before? And if you're in doubt, you can even ask them to show you, photographs of when they were younger. Have you been using any ocular medications or any systemic medications? That may give somebody an idea that I think you already had poor vision. That's why you are prone to the injury. Of course, it's very important to take history of drug and alcohol abuse. And this is important not only for their future rehabilitation, but more immediately, if that patient is going to go in for GA, then you need to know if they've been taking alcohol, because then they'll respond differently to your pre-medications and the anesthetics that you use. That history is also important, because somebody like this is going to come back with another injury before very long. I mean, your typical alcoholic, when you see them in the wards, they have all these injuries on their face, a mixture of old and new injuries. Now, I really need to emphasize on the legal aspects here. Negligence is generally defined as doing an act or omitting to do an act that a reasonably prudent person under the same circumstances either would not do or fail to do. So sometimes the negligence may come in form of the outcome has been disappointing. So the patients go back and sue, and the lawyers want to come back to the files and say, was it just the injury? Was it also the care that the patient got that was negligent? So medical negligence is now attributed to the doctor, in accordance to, did he act in accordance to ordinary medical care and skill? The only evidence you have is your notes, unfortunately. I should mention here that from our experience, most medical legal issues don't arise immediately after. Actually, they take almost 2 to 3 years. By that time, you probably have long forgotten. The patient obviously has not forgotten, because this has been an issue for them. But I find it unfair when you go to court that they believe the patient's memory, but don't trust the doctor's memory. For you, the only thing they believe in is a medical record. So make sure that that record is accurate. Don't alter information in records. And for sure, if you have to alter anything, there's a way we've taught you how to alter them. You draw a vertical line across and a bar up and down, and you sign, not scratching things across to obliterate them. When you're making those records, just write what you're sure of. Don't write what would be considered hearsay. So, for example, the correct way to report something is the patient says he was injured by a colleague. Don't say the patient was injured by a colleague. Or like what we tend to write a lot in our medical files, the patient was assaulted by somebody known to them. Don't say the patient was assaulted by somebody known to them. The patient reported that he was assaulted by somebody known to him or her. That's the accuracy that is required here. The injuries will generally be, the compensations people will be looking for are broadly going to be either towards the perpetrator of the injury. Some of the complaint will be to the caregivers, the doctors and the hospitals. Others will be looking for workman's compensation because they were injured in the workplace. And so regardless of whether they were wearing eye protection, which has even been provided and hangs on the walls, and many of them don't like to use it. When they hear somewhere that you can be compensated and get money, they'll take it. A lot of these injuries, I should tell you, also may result in loss of occupation. If you lose your vision in one eye, and you're a Juakali guy who makes furniture, or you make, all the metalwork they do, and you've seen how skilled these people are, or you work in a factory where there's a conveyor and you offload things from a conveyor. If you end up with a loss of vision in one eye, you have lost your visual field, you have lost your stereopsis, you can't judge depth. Then it means when you start hammering things, you can easily hammer your finger. If you're trying to get things off a conveyor, you can easily cut your hand again. So one injury could easily lead to another. And that's really important to take note of. I think we've kind of mentioned this earlier. I should match my slides. When there has been assault, it's also nice to say, have you reported to the police? Because sometimes the medical record is used to corroborate some of that information that's being presented in courts. So that's history. Examination, I'm sure you've learned it from when you started coming into the wards, that we generally inspect, we palpate, we auscultate. We'll cover this in more detail when you come for your clinical rotation. So generally in the 4th year, as much as possible, we'd like the tutorials to be done with the patient. You may notice with some of your older colleagues, the 6th years, that because of COVID and reduced patients and all that, we had already done this with them in 4th year. So in the 6th year, we give them online tutorials just to review the work. But for your group, I really would want you to, as much as possible, see patients. In the initial assessment, first things first, I'm sure you've heard of ABCD. You want to first make sure that you're dealing with life-threatening problems. Is the airway okay? Is the patient breathing? If they have had a fall, is the cervical spine protected? Is there, breathing, ventilation, circulation, disability? I'm sure you've done all this. Exposure and environmental control. If the patient is unconscious, because you may be called to casualty to see somebody who's been multiply injured, they're unconscious, but they also have an eye injury, they may be having a brain injury. Some of them may be having psychiatric disease, and also something we are now beginning to see a lot, substance abuse. Note the general health status of the patient. Somebody who's malnourished may be having liver disease, so they're at risk of bleeding and poor wound healing. Somebody who's malnourished, it probably means this is also fairly common, especially with people who abuse substances like this. So those are subtle observations you make. Now, in terms of the eye, we generally go from forward to back. We're going to practice this over and over and over with you in the 6th year in the tutorials. We look at gait. How is a person walking? That can give me an idea of this gentleman. Does he have a stroke from a head injury or from a vascular problem? Head position, scars and swellings. Then we go to the eyebrows. These are things we look at in more detail. We'll talk in the tutorial. From the brows, you go to the lids. From the lids, you go to the conjunctiva and the sclera. Then we get into the anterior chamber, and we go back to the iris, pupil, lens, retina, and vitreous. So you notice we go from front to back. This is the principle of eye examination, whether trauma, whether anything else. That, I said, we'll do in the tutorials. So finally, after you've taken a history and examined the patient, and the general principles of management, which are a nice thing for you to remember, is hataris. H for history, and we've talked about history. A is assessment. Assessment is a combination of your examination and any imaging or tests that you do. So based on your examination, you may think, I suspect this and the other injury. I probably want to have a CT scan. You may want an MRI. You may want an X-ray. This patient is going in for GA. They'll probably need to have a hemoglobin and renal function test done. Then if they haven't, T is for tetanus toxoid. Is that up to date? If they have had a penetrating injury, we want to prevent, especially when there's stones, soil, sticks, and things like that involved. We want to avoid having tetanus. The A is analgesics and can also be antibiotics. R is for refer, I is immediately. Please refer immediately. We talked about the data, how long it takes for people to come. And the S is for a shield. A shield is better than an iPad. If you don't have a shield, then use the pad, but the shield is better. When you come to the wards, we'll show you a shield. It's shaped like the palm of your hand with perforations or little holes. They're made of plastic. They are good for protecting the eye from further injury, but they also don't press on an open globe. And refer immediately, depending on where you are. I took this picture from a slide of something we used to watch in our earlier years. There was a series called ER. I don't know what the series of medical series these days are. And there, everything was always hurry, hurry, hurry. But always remember that, there are places in the world where the ambulance is what you see on the left. And sometimes there's no ambulance. So this is a study I published with a colleague when I used to work in Gichuhi Hospital. When I finished my med, I worked at Gichuhi Hospital for a few years before coming back to the university. And we were looking at people who had had an injury and took so long to come. Blunt injury, young patients who had had traumatic cataracts and took too long to come or to have surgery because we had noticed there were interesting outcomes. So we found that if you delayed more than a year, you've had a cataract more than a year to repair. Those are the ones we were calling cases. There was a difference in the length of that eye compared to your normal eye. A difference that was almost 3 millimeters. For the others, if they were repaired earlier, and this was, I'm talking about a blunt injury, so the wall is not defective, but the patient has sustained a traumatic cataract, then there was very little difference between both eyes. And that's really important because if you have a difference of up to 3 millimeters in length, when we are doing cataract surgery, we measure the corneal curvature and the axial length and use them to combine them in some formula that tells us what power of intraocular lens do I need. And so the basic summary here is if you have a millimeter difference between what is right and what you've measured, then you have up to 3 diopters. So with 3 millimeters, you're talking about a 9 diopter error. Now, this is a patient who may have an injury, perhaps even with a scar or something where you're not able to measure that eye very well. So people tend to use the normal eye and estimate from there what they need for the injured eye. And you can see here that you can go wrong. So it's really important. Don't, if it's in your power in every way, when people have injuries, let them be assessed and treated appropriately first time round. I also looked at some data from some of the studies that have been presented in our conferences. We have an ophthalmic conference every year that brings together all our East African countries and now broader East Africa, going all the way to Ethiopia, Rwanda. And people present their data there. And this was Alatas looking at some work he did for his study in his MED in Dar es Salaam. And they were looking at reasons for delay in appropriate management of injuries in Tanzania. And late presentation was one. Of course, when we say late presentation, that's also a whole area that you need to unravel. Why do people come late? They live far, they are poor, they have to travel long distances. Awareness. So this is a loaded statement alone. Then even for those who had care, it was inappropriate, inappropriate care along the way, both formal and informal. People use all kinds of, home remedies to put in eyes, and when it doesn't work, they come to hospital. The other important thing was actually injury on a weekend, which is interesting because if you're injured on a weekend, you're most likely coming to hospital when it's the junior people who are first on call, the senior, more experienced people may be away. In every department, whether it's nursing, theater, the medical personnel, some of the specialized investigations may probably not be available during the weekend. So the weekend is a bad time to get injured. And yet we know in this town, especially, and I'm talking to people who are in this young age group, most injuries occur on weekends. Most surgeons will tell you Friday night, Saturday night, they are very busy. So many people in this town get injured and die on weekends, and mostly related to a lot of partying and drinking and the high risk behaviors that come after that. So referral systems are often dysfunctional, and this tends to apply across the area. When you're referring somebody, they're not even sure what time the place you're sending to opens or closes. They don't know how much it will cost for them to open a file. So when you finish and you're now working in a county hospital somewhere or a sub-county hospital and you're referring somebody, please try and find this information before. Because when they know, they can plan. So typically when you refer somebody, they go back home, they try and gather some more money to do the next longer journey and preparing for costs they're not aware of. How much do they charge? They don't know. So this is good information to provide to someone. And if possible, if you're referring to a certain hospital and you have a friend in that hospital, call them and ask them, I'd like to refer someone. What's the best way for me to refer somebody with an eye injury? Is it to come to the casualty or to come to the eye clinic? So for example, in KNH, anybody with an injury who comes straight to the eye clinic any weekday, there are registrars and consultants there every day, Monday to Friday. So we see fresh injuries coming straight in, either from referral or primarily they come straight to the eye clinic. And that's faster than having to go to the casualty first. Of course, if you have other injuries, you may have to go to the casualty. But that kind of information is good because then if you call somebody in that hospital, they can direct you and say, just send that patient straight to the eye clinic and they can be seen by the people there and appropriate decision and management begun. Referral systems are also poor because of a lot of staff absence. And some of these places are very poorly, I was going to say manned, but I think we have been cognizant that we also have women working in these places. You are alone in a facility, you never go on leave. When you go on leave, everybody now gets referred. Sometimes you have inexperienced staff deputizing for the more experienced people. So referral systems, although this was a study in Tanzania, they are fairly generic problems across our region. And I hope, by the way, some of you will get interested in things like public health and health economics, because we need doctors who start to understand the big picture. So you don't always have to aim for a career as a subspecialist in something. There is much more you could do in healthcare. So what do you do with an open globe injury? Basically, inspect the eye without pressing it. We tend to use retractors if you can, so don't try to squeeze open eyes. You will just be causing more harm, especially in a child. Immunize with tetanus. I think these are repetition of Hatari. IV antibiotics. It's nice to know when the last meal was, if it's a patient who you think looks like they need surgery. Even if you're referring them to a place where they need surgery, then it's nice to record the last meal. The rest is about investigations, which we'll talk about in the tutorials. I thought I should talk about, and this slide is badly titled, it should be medical treatment of severe chemical injuries. Chemical injuries are an emergency. Copious irrigation with normal saline for 15 to 30 minutes. Use a liter or two of normal saline. Put a giving set, open the eye, and just let that fluid run through the eye to wash out and to dilute whatever is there. Topical steroids in the first weeks to help to reduce inflammation. If you have ascorbic acid, drops or systemic, that would be good to enhance collagen production. Citric acid, we used to have this at Gichuhi Eye unit to inhibit neutrophil activity. And then later on, after a week, we can give them topical or systemic tetracyclines to inhibit collagenase. I think you'll get a lecture on chemical injuries later. So how do we prevent them? Because we've noticed some of these people take so long to come to hospital. If we could prevent it, that would be better, isn't it? I think we tend to use the word accident very often, or it was just an accident, I'm sorry. But the reality is most of the factors that lead to these so-called accidents are not outside human control. An accident is something that is outside human control. But if you think of all the things we've talked about this morning, they are not outside human control. Kids playing with dangerous things, that's not outside control. You can do something. Kids play with because they have no toys. So some of your friends who are doing engineering and others doing business. If you share these ideas with them, who knows, people can start coming up with cheaper, less effective, less costly toys for kids to play with. So injuries are often preventable, whether eye injuries or otherwise. Some of the factors we've talked about, alcohol and drugs and things like this, those are preventable. If you stop that, you stop injuries. So the first step towards prevention is, first of all, just to understand the causes and the epidemiology of your injuries. And you can see that was the genesis behind some of the studies we did in KNH. We tried to establish a trauma registry. This doesn't always happen. It takes a lot longer to do that, but if you're able to establish registries, that helps. The use of protective eyewear is really important to promote. Helmets, you've seen border borders, how they don't wear helmets. Protection in workplace, goggles, and enforcement, seat belts and helmets, and safety equipment in workplace. Construction sites, for example. Preventive intervention you could also offer is just teaching first aid. So, when you're posted as a doctor, wherever you'll be working, if you're working somewhere near Kitengela where there's lots of factories, or there are factories around where you'll be, or in the farms, during the health day or some of those things, some of the churches, for example, will have health weeks. Some of the NGOs will have some health promotion week somewhere. Get involved. And one of the contributions you can make is just teaching people how to do first aid, how to wash an eye after a chemical injury. Some of the commonest chemicals that injure our people are fertilizers and sprays. And of course, advocacy and media campaigns. So start making friends with your friends who are in law school, people who are doing media and communications. Share these kind of discussions when you learn. Because then you start to awaken them to something they may not be aware of. And you may need the skills to create good media campaigns. There's a long list of things here that you could do at the individual level, which I will send around for you to read because we are just at the top of the hour. Some examples of protective eyewear, from military to industrial to sport, even to, this was a picture of actually somebody, the bottom right was somebody who had actually made something to protect himself working in the Gichuhi industry. So sometimes you think you have the solutions, but the solutions are out there. And rehabilitation, it's very important that somebody who gets injured in one eye doesn't get the other eye injured or the same eye re-injured. So before they go home, please tell them about how to wear protective eyewear, plain spectacles, just to prevent further injury. Some people may not be able to go back to their jobs, so they need to have that kind of counseling while they're still at the hospital. You may need to change your occupation. Sometimes we need rehabilitation, and we have low vision services in some hospitals, like Kenya Society for the Blind has one, Gichuhi Eye Hospital. You also need to educate them. Somebody in the hospital needs to educate them about the disability benefits that are available. So managing the, remember I earlier said we don't manage eyes, we manage patients. You have to carry the story all the way from treatment right up to rehabilitation. And I think that's my last slide. Those are my references. So just to recap, we quickly talked about earlier the terminologies and classification. I think we've given you data about the epidemiology of injuries locally, mentioned what's important to emphasize in history taking. The examinations of the eye, we covered just the principles. We'll do that in detail later. Principles of managing eye injuries. We mentioned at the end prevention and rehabilitation. I think it's time for me to stop. And with that, I'll stop sharing. And it's just 8 o'clock, but I think we could take one question or one comment anybody may have. So any question? Any comment? Very good then. So thank you very much. Khan, I'm sorry, I have an unstable connection. That's a message I got. Okay, I'm done. I will email this to you, Khan. And
Thank you, Dr. Gichuhi. Yes.
I'm glad to have done this. So thank you, all of you. We'll see you later on in the year. All the best.
Right. Thank you. Have a great day ahead.
You too.